The topic is mitral regurgitation. What's happening here is there is an incompetent mitral valve, as a result of which there's a retrograde blood flow through the left atrium. And the problem with the mitral valve is at different levels. It could be at the level of the valve, wherein the annulus and the leaflets could be um, affected, and it could be at the level of the subvalvular apparatus, where chordae tendineae and papillary muscles could be affected. And often there's ventricular problems as ventricular dysfunction and with annular dilation. It's often important to understand the mechanism involved in the MR and whether the process is an acute versus it's a chronic. Several conditions lead to MR, and mitral valve prolapse as a condition in itself does not require a valve replacement, but commonly it's producing MR, and in that condition, in that situation, there is a need for a valve replacement. Then rheumatic heart disease can lead to MRs and endocarditis, and several conditions such as the calcified mitral annulus and hypertrophic cardiomyopathy, dilated cardiomyopathy, and idiopathic myxomatous degeneration of mitral valves, myxomas, SLE, fenfluramine, dexfenfluramine, and ruptured chordae tendineae and papillary muscle dysfunctions as a result of ischemic heart disease. And of course, following endocarditis. There are many conditions, in a nutshell, those can produce and lead to MR. What's happening in dilated cardiomyopathy is annular dilation as a result of ventricular enlargement, and the ventricular enlargement and remodeling basically leads to papillary muscle displacement and leads to inadequate leaflet coaptation. In ischemic MR, of course, there is annular dilation as a result of ventricular enlargement, and then there is a left ventricular remodeling with papillary muscle displacement, and also there is inadequate leaflet coaptation, and and in acute situations, they could be papillary muscle dysfunction and ruptured chordae tendineae, as seen in situations in acute MI. Rheumatic reasons used to be at one time most common cause for the development of MR, and in rheumatic heart diseases, what's seen is basically at times a combination of both MR and MS, and there is a leaflet thickening, and there could be calcification of the leaflets and the quads as well. In infective endocarditis, there is destruction of the leaflet tissue, as in perforations, and acutely in situations such as ruptured papillary muscle or ruptured chordae tendineae or infective endocarditis, acutely there could be presentation of MR, and acute MRs may require emergent surgical repair, as in situations of arising out of MRs due to myocardial infarctions and ruptured chordae tendineae and endocarditis. Chronic mitral insufficiency may remain asymptomatic for years. In acute MRs, what's happening here is basically there is a sudden large volume load on the left atrium ventricles, and there is an increase in the left ventricular and diastolic pressure and increase in the left atrial pressures. And what's happening is the left ventricle tries to maintain the stroke volume, and there's increase in heart rate and contractility. So although there is a supranormal ejection fraction, but because of the blood being ejected backwards due to the lower resistance of the left atrium, the stroke volume is often reduced, and there is hypotension. And pulmonary edema, of course, due to increase in the left atrial pressures. And folks have tachycardia, tachypnea, and often progressing to respiratory distress. And the murmur is asystolic murmur. The murmur is not very impressive and may just sound like an ejection murmur. And the murmur may not be holosystolic or may be absent. And there is relative hypotension, even shock-like situations. And of course, there's development of pulmonary edema, and acute MRs may lead to an abrupt tall V waves, and basically there is also a low cardiac output as mentioned before. In chronic MR, the situation is more gradual, and as the volume load is imposed on the left atrium and ventricle, there is an increase in the left ventricular and diastolic pressures and the left atrial pressures. There's left ventricular dilation over time, and there is development of left ventricular hypertrophy as a result, and so there's a situation where there is an increase in preload and left ventricular hypertrophy, and what's happening is the left atrium is providing unloading for the left ventricle, and initially there's supranormal ejection fractions, but what's happening over time is there is a contractile dysfunction and there's a decrease in ejection fraction, and there is an increase in the end-systolic volumes, and there is an increase in the left atrial pressure, and there is an increase in the left ventricular and diastolic pressure at given volumes. And finally, what's happening is there's development of pulmonary congestion and pulmonary hypertension, and there's a reduced forward stroke volume. And in chronic mitral regurgitation, the murmur is pansystolic and it radiates to the axilla, and the murmur is apical. And there is a hyperkinetic left ventricle. And in chronic MRs, the murmur intensity decreases with Valsalva maneuvers and with amyl nitrite, whereas the murmur intensity would increase with the hand grip and the squatting maneuvers. Left ventricular impulse, one can say that it's a hyperdynamic or a hyperkinetic left ventricle, and so therefore the displacement wise it will be downward and more towards the left. And there is an S3, and this is due to rapid filling of the left ventricle, as the left atrium accumulates large volumes of blood during systole. And as a result of rapid filling of the left ventricle, there is an S3. Chest X-ray would show left atrial enlargements, left ventricular enlargements, pulmonary congestion, enlarged pulmonary arteries, cardiomegaly, and ECG, one would appreciate atrial fibrillation and left atrial enlargements and left ventricular hypertrophy, and findings related to these would be seen on ECG. Also, there could be from previous MI, especially in ischemic MR, there could be findings related to those. Echocardiography is a great test to diagnose and quantify the MRs. The TTE is basically any left ventricular dysfunction, make an assessment of the ejection fractions, and in chronic severe MRs look at the dimensions of the left ventricles and the left atrium. TEE would be utilized in situations where the TTE is non-diagnostic, and TEE would help determine the severity of MR in those situations, and also to better look at the anatomy of the valve and to look into situations such as if the endocarditis is present, and also to look at the feasibility of the repair. 3D echo can be utilized to have a more precise anatomic insight and prove very helpful in situations where the repair is needed. MRI can be utilized in situations where the echo is non-diagnostic, or the in situations where the ejection fraction cannot be assessed adequately by an echo. In those circumstances, to have a assessment of the MR severity and to have an assessment of the ejection fraction. Right heart catheterization would help into situation if there is development of pulmonary hypertension in folks with chronic severe MR, or to have an assessment of the left atrial filling pressures, and also presence of V waves on pulmonary capillary wedge pressure tracings would also help suggest the severity of the MR. One would utilize left heart catheterization, particularly in folks undergoing mitral valve surgery and who would have had any risk factors for coronary artery disease, and therefore an evaluation of coronary artery disease in such folks with risk factors and undergoing mitral valve surgery, left heart catheterization would be helpful. And left ventriculogram can help look into the severity of the MR and also give an assessment of the left ventricle function. Medical management wise, taking care of the ventricular response of atrial fibrillation is there, and utilization of anticoagulants in situations of atrial fibrillation. And then afterload reduction may be accomplished with the help of certain medicines. And, and afterload reduction can help with a decrease in regurgitant fraction and in helping improve the cardiac output. For folks who have acute conditions and are awaiting surgery, there could be utilization of IV nitroprusside and IABP and help reduce the levels of MR and help in stabilizing the patient. And basically how it does is basically improves the forward flow of the blood and also reduces the pulmonary edema. And it's important to keep at the back of mind that such folks are often heart rate dependent for maintaining a cardiac output. For folks with chronic functional MRs, treatment would be very similar to those with folks having left ventricular dysfunction. ACE inhibitors and the beta blockers have shown to reduce mortality. May also need cardiac resynchronization therapy, which also reduces the severity of the. Percutaneously, there are several approaches targeting the various components that help contribute to the development of MR, such as the lack of leaflet coaptation or the annular dilation. Mitral clip is one of the device that is very helpful in pinching the leaflets together, and the idea is to enhance the coaptation of the leaflet. From a surgical standpoint, valvular repairs are superior to valvular replacements whenever feasible technically, and the valvular repairs have reduced operative mortality, and they do not require any anticoagulation, subsequent anticoagulation. Several factors would be important when looking at the operative or the post-operative mortality, such as any associated coronary artery disease or atrial fibrillation, and the left ventricular dysfunction and the NYHA functional class. Indications for the surgery in mitral regurgitation would be looking for candidates taking into consideration several factors such as the chronicity and the severity of the MR and the NYHA functional class and the left ventricular dysfunction and the end systolic dimensions.